Hi, thank you, Brittany. This is my second one of these BPH webinars. The last one was last summer. I don't know if anybody saw that, but this will be very similar. This will be available, I think, afterwards to reference back to on our, I believe, our Facebook page, and I don't know how else, but my talk will take 30 minutes or so, and then happy to ask any questions that you guys might have. So I'm to tell you that you can't record audio or video of this, according to Boston Scientific. This is me. I practice primarily, so I'm with Urology of St. Louis, which is the largest private group in St. Louis, one of the largest in the country, actually. There's about 25 of us urologists in the group. My primary offices are at the Walker Medical Building, which is off of 40 and Mason Road. About half my time there and about half my time at our office that we rent from St. Elizabeth Hospital, which is in O'Fallon, Illinois. I also go periodically, a couple times a month, to Parkland Hospital down in Farmington, Missouri. Sunset Hills, BJC has an office that we rent out. And then Fairview Heights, which is over close to our St. Elizabeth's Hospital. Our phone number's there, our website's there. As Brittany said, I grew up in Cape. I went to SLU for undergrad, went to Mizzou for med school, and I did my surgical training at Mayo Clinic in Arizona. So we'll talk about the prostate today, how it can cause trouble, what we can do about it, what it is, and what it's good for and what it's bad for. So the prostate's a gland that helps out in reproduction when we're younger and generally causes trouble as we get older. The prostate makes most of the ejaculate, and it's a gland that sits right where your bladder funnels. Your bladder is a big bag of muscle that stores your urine, contracts down to empty out. So when you pee, urine doesn't just fall out of you. That bladder muscle does a contraction to force it out under high pressure if your bladder's working correctly. That's a type of muscle called smooth muscle, so like your heart. So that contracting your bladder muscle is not under your conscious control, just like you can't think about it and make your heart beat. What happens when you're in the bathroom, your brain releases its hold on your bladder and your bladder reflexively contracts down to force the urine out of you. And you pee right through your prostate. I think this second bullet point here is not quite exactly how I would describe it, because I think that confuses people. The first part of the urethra is the prostate. So I would not say that the prostate wraps around the urethra. The first part of the urethra is the prostate. Prostates, when we're younger, in high school, probably about 15 grams. Generally, in adulthood, starting 40s or so, the prostate starts to grow. Sometimes it grows a little bit, sometimes it grows a whole lot. But generally, it just grows as we get older. So that's what the prostate does when it's working correctly and when we need it. As we get older, prostate can get bigger and tighter, and that causes a lot of the urinary symptoms that most men get if we live long enough. It's almost an inevitability that we will have trouble urinating, and that is generally from prostate. So prostates can cause BPH, which causes lower urinary tract symptoms. Prostates can get infected, we call that prostatitis. Prostates can get cancer. Prostate cancer is one of the most common cancers in men. Very manageable as long as we find it early. We screen for prostate cancer with a prostate exam and a PSA blood test. PSA generally finds prostate cancer about a decade before it causes any obvious signs. So the symptoms that guys get, weak stream, et cetera, that we'll talk about, usually not a sign of prostate cancer. The signs of prostate cancer is a PSA that's going up. So BPH, benign prostatic hyperplasia, is what that stands for. And essentially what this means is, over time, that prostate that we pee through can get bigger, can get tighter, and can start to restrict the flow of urine from our bladder out into the toilet. And that generally causes most of the symptoms that men get. Again, I mentioned this, but BPH is a separate issue from prostate cancer. So The symptoms that men get are generally not because of prostate cancer, as long as guys are getting screened for prostate cancer. Like I said, we usually find that about 10 years before prostate cancer causes any trouble. Now, you can have both bothersome urinary symptoms and also have prostate cancer, but one does not necessarily mean the other. Last point about PSA. Primary care doctors generally have a threshold of about 4 to say that the PSA is, quote unquote, too high. Urologists think about PSA in a lot of more complex ways than that simple cutoff value. One of the most important ways is size of the prostate. So bigger prostates make more PSA. So again, just because a PSA is high doesn't mean that you've got prostate cancer. I mean that you might. Also means that you might have an inflamed prostate. Also means that you might have a big prostate. So again, BPH and prostate cancer, separate issues, and we evaluate them differently. This is a good picture to demonstrate what we've been talking about. On the left, normal prostate, small, urine flows freely from the bladder out into the toilet. On the right, prostate's gotten bigger and tighter, starts to restrict that flow. I usually give guys, when I'm talking to them in the office, an example of trying to water your lawn, turning on the faucet, standing on the hose. And all the things that would happen to that garden hose happens to our urination stream, gets weaker, dribbles out, etc. And each year, generally starting in about our 50s, your foot's just applying a little bit more pressure on that hose, slowly but surely. I think it's very helpful to think about the prostate like an orange. The prostate is exactly like an orange. Prostates have capsules, which is like the rind of an orange. Incidentally and interestingly, dogs are the only other species that we know about that have a prostate capsule. But human prostates have capsules like the rind of an orange, and they have pulp. And that's called adenoma. Adenoma just means overgrowth of a gland. And so, and guys pee right through the middle of that. So just like there's a little divot running through the middle of an orange, that's the channel. And so when we're younger, we're peeing through a clementine, nice wide open channel, small prostate. And over time, prostates get bigger. And so some guys get a very, very big prostate, peeing through a big Florida orange. And so you can imagine how that would cause your bladder some grief. Symptoms are generally, we think about symptoms for guys in 2 broad categories. One is obstructive symptoms. And those are all the things that I've been mentioning. That's weak stream, taking longer to urinate, not emptying out the bladder. Sometimes hesitancy, where you go to the toilet and you got to pee, but it takes you 15 seconds to get started to generate enough pressure to get the urine out. Intermittency, the Kaminsky method, which is a great show on Netflix. They call it Morse code. You pee out a little bit, pee out a little bit more. All those symptoms of something in the way, those are obstructive symptoms. And sometimes that problem is bad enough to completely obstruct the prostate. And oftentimes guys who have a real problem with this will have to go into the ER and get a catheter put in. Catheters basically bypass the prostate and drain the bladder directly. So if this continues unchecked, total retention is sometimes an issue for folks. The other broad category of symptoms that people can get are irritative symptoms. So that's urgency and frequency. Those are bladder issues. So women can have irritative symptoms. Women don't have prostates, but women can have irritative symptoms, and that's a bladder muscle sort of problem. And so sometimes that bladder muscle for guys, when it's been obstructed by this prostate, can get irritable, and we call that overactive. And so that bladder muscle can send the signal that you got to pee all the time. And sometimes it sends that signal pretty darn strongly and makes you drop everything you're doing and run to the bathroom and hope you don't leak on the way. And that's a bladder spasm. Again, bladder's a big bag of muscle, and it can spasm like other muscles. And those are symptoms of an irritated bladder, often in men caused from an obstructive prostate. Most men deal with this. 2/3 of guys on Medicare, so 65 and older, take medications or have procedures for their prostate, about 90% of 80-year-olds. So as I said earlier, this is almost an inevitability. And obviously this affects quality of life. 15 million men had this issue a decade ago. It's probably higher than that. So a lot of guys ask me, why does this happen? Why do prostates grow? And the answer is testosterone. Being a guy, unfortunately, other things that are in our control, they cause worsening lower urinary tract symptoms. Being overweight, not exercising enough, those things have been shown to worsen this urinary issue. So all the things that are good for your heart, generally good for your prostate as well. So getting some exercise, eating right, losing weight. So when you come see a urologist, and hopefully your primary care doc's doing some of these things as well, we evaluate some of the easy things that we can do quickly. When we first see you, check your prostate, a digital rectal exam. A lot of guys say, oh, I just got my colonoscopy, but your prostate is not part of your colon. It's not part of your gastrointestinal tract. Your bladder and your prostate just happen to sit directly on top of your rectum. And so with a finger in the rectum, we can feel the back of the prostate. We get some sort of sense of size from that. It's not accurate enough to go off of, but what we're really evaluating is for a nodule on the prostate, and that can be a sign of a cancer. So when we do that rectal exam, we're feeling for something scary. Generally, when I see guys for the first time with BPH, and oftentimes for follow-up, we check what's called a post-void residual. So we have you pee, we have you do your best job of emptying out your bladder, and then we check with a little handheld ultrasound to see what's left over in there. In a perfect world, you empty out everything when you pee, but we don't all live in a perfect world. A lot of guys retain a little bit of urine afterwards. If that number starts to creep up over about 200 milliliters, which is roughly 7 ounces, a little bit under, that sets guys up for urinary tract infections, which are always unusual in a guy. Potential damage to that bladder muscle if it's retaining too much urine, that can stretch out that muscle a little bit like a rubber band. And if the problem is severe, then potential kidney damage. I've seen guys in the hospital on dialysis because of this problem. So emptying out your bladder completely is the goal. Adequately is good enough. And what that means, again, is usually below about 200 milliliters. So we check that in the office. We usually check a urinalysis, and that looks at things like protein in your urine, which can be a sign of kidney disease, blood in your urine, which can be a sign of bad things, sugar in your urine. I've diagnosed a couple of people with diabetes that they didn't know about because they were spilling a bunch of sugar, and inflammatory cells, which might indicate infection. So peeing in a cup tells us a whole lot about your urination. Oftentimes we'll check a PSA if it hasn't been done by your primary care doctor, but they're usually pretty good about that. And we usually make you fill out questionnaires like everybody now. Every time you go to the doctor, I know there's a lot of questionnaires to fill out, but these questionnaires like the IPSS or the AOA symptom score, these are validated questionnaires. In other words, the questionnaires themselves have been the subject of published literature. And so we really track our outcomes based on these questionnaires. So it's not just busy work while you're waiting for us. We really do pay attention to those symptom scores. So treatment-wise, there's a whole spectrum of things that we can do, from nothing to pills to procedures to real surgery. Talk about those. A lot of guys ask me about supplements. My general thought, if you go to Walgreens or CVS, you will be able to find 20 different things that are meant to, provide prostate health, which is a very generic sort of term. So a lot of guys ask me about those. Firstly, supplements are supplements because they have not been studied by the FDA. And so I don't know whether they're going to cure cancer or make you grow a third arm, because we don't know, because they haven't been studied. That's what makes them supplements. In terms of medications, we know what side effects people have because they've been studied in tens of thousands of men. If there was something that was in the Super Beta Prosta Max Health supplement that you can get at GNC, then some pharmaceutical company would have packaged it, patented it, and sold it to you. So a lot of guys take supplements. I generally don't recommend that. The caveat is all of them have saw palmetto. That has been studied a little bit and probably helps a little, probably not enough to make it worth the cost. But in general, my thought on supplements is that if they worked, they'd be medications. So doing nothing about this, this sort of bothersome urination isn't going to kill you, but watchful waiting does potentially have risk. So again, that's one of the reasons we check how well you're emptying out your bladder. Some guys come in and say, I'm feeling great, leaving behind 500 milliliters in their bladder. And while that may not have any immediate consequence, that will down the road cause long-term issues. And eventually, again, that bladder muscle sometimes gives out, stops working, and there's not a whole lot we can do about that. But as long as you're emptying out, as long as you're not getting infections, and as long as your symptoms are under control, you don't have to do anything about this. We usually talk about, especially for getting up at night, trying to limit fluids for about 2 hours before you go to sleep, which is an easy thing with no side effects that you can do that might help. As we talked about, losing a little bit of weight, getting a little bit more exercise, those sorts of things help. There are certainly some medications that can make this problem worse, specifically diuretics, like furosemide, Lasix. The way that works is it makes you pee all the time. So that can make this problem worse. Hydrochlorothiazide is another common diuretic that does the same thing. And you may, if we just watch this, at some point you may miss your window of having a nice, quick, easy thing like a Resume or a Urolift, because those have size limits to them. And so if we don't do anything when your prostate's 50 grams, when your prostate's 100 grams, your options are different. A lot of guys take pills for this. 2/3 of guys on Medicare are on medications for their urination. 90% of 80-year-olds take medications for their urination. The two common medications are alpha blockers like tamsulosin or Flomax. The other medications in that class, silodosin, which is Rapaflo, and alfuzacin, which is uroxetrol. All those relax the prostate a little bit. They don't shrink the prostate, but they stop it from being clamped down so tightly. The effect of these medications is generally seen pretty darn quickly. So for example, guys who are on something like Flomax, when they miss a day, they know it. Guys who go out of town for the weekend, forget their Flomax, they're hurting. So this works pretty quickly. Very common medications. Tamsulosin's been around for decades. It's cheap. It's generic. What I usually caution people about with tamsulosin, can cause a little bit of lightheadedness when you pop up from a chair too quickly. And about 20% of guys get something called retrograde ejaculation, where when you orgasm, nothing comes out. That's not dangerous to you, but it bothers a lot of guys. But Flomax is extraordinarily common and generally benign. The other medication that is commonly used are 5-alpha reductase inhibitors like finasteride or dutasteride. Finasteride actually is the exact same medication in Propecia, which a lot of guys take for hair loss. Finasteride's been around for decades, cheap, generic, long track record. These shrink the prostate. They take 6 to 12 months to do it. Finasteride has been shown not only to improve symptoms, but also to decrease the chance that guys totally block up and have to go in and get a catheter put in the ER. Tamsulosin doesn't do that. Finasteride does. And decrease the chance that we do a procedure or surgery on your prostate. So For guys with big prostates, again, finasteride and dutasteride work by shrinking your prostate. For guys with big prostates, it's a great pill. About 5 to 8% of guys will have some sexual side effects, maybe some erection problems, maybe less interest in sex, but the majority of guys don't have any side effects from this. The other medication that I don't believe we have a slide on is tadalafil, which is Cialis. That is FDA approved in a low daily dose to help with urination. Cialis for erectile dysfunction is a 20 milligram pill. Cialis for BPH is a 5 milligram pill once a day. So for guys, tadalafil, Cialis, probably not as effective as tamsulosin or finasteride in terms of urination. But for especially younger guys with just a little bit of trouble with urination and a little bit of trouble with their neck erections, that daily tadalafil is kind of a nice pill. Cialis has recently gone generic, so not nearly as expensive as it once was. So those are the pills that we use. In terms of procedures, there's two fairly minimally invasive procedures, Resume and UroLift. Resume we do in the office. We numb everything up. So we put an ultrasound in the rectum, like when we do a prostate biopsy. We can inject lidocaine into the nerves to the prostate. So we numb up the prostate that way. We put numbing jelly in the urethra, let all that sit for about 10 minutes. If you have somebody to drive you, I generally send you a pill of something like a Xanax and a pain pill to take about an hour ahead of time, but no hospital, done in the office. You go home that day. Procedure itself takes about 5 minutes. We put a scope through, inject steam into the prostate. Each treatment takes 9 seconds. Usually we do that somewhere between 4 and 10 times, depending on the size of the prostate. Have a catheter for somewhere from a couple days to 1 week. The catheter comes out. And for the first few weeks after that catheter comes out, a lot of guys will almost feel like you've got a UTIs, maybe some urgency, maybe some frequency, maybe some stinging. What's happening is that prostate is remodeling, and where that steam was delivered, those parts of the prostate are dying and being reabsorbed, and prostate shrivels up basically. But that can be a little bit irritable for the first couple weeks. I see guys back at a month, and by then they're generally doing pretty darn well. I think we have a video about that that we'll play here.
Resume water vapor therapy is a non-surgical treatment for BPH. Resume uses the natural energy found in steam to shrink the prostate. In just seconds, this precise technology destroys enlarged prostate tissue while minimizing any effect on surrounding tissue. Resume is a potential alternative to drug therapy, permanent implants, and surgery. It preserves sexual and urinary functions, and it's clinically proven to safely and effectively reduce BPH symptoms. Potential side effects include painful urination, blood in the urine or semen, pelvic pain, and urinary frequency, retention, or urgency. The procedure is performed right in your doctor's office or outpatient center. You do not need general anesthesia for the procedure, and Resume therapy lets you quickly return to normal activities. Talk to your doctor about Resume if you're no longer comfortable with your BPH symptoms. Drug therapy isn't working for you. The side effects from drugs are impacting your quality of life.
So we can stop there. Talk to us if you have questions about Resume. Here's a little patient testimonial that's about a minute long. Here.
I found out that I had BPH. My symptoms were a slow stream, and I would wake up frequently in the middle of the night. I first heard of Resume when I was researching enlarged prostate and the procedures to repair it, to fix it. And Resume was one of them. The more I researched Resume, it was the latest and greatest technology, and I want to be part of new technology. I think technology is good. My experience with the Resume procedure was very good. After the procedure, I was a little worn, a little tired, and the next day I felt fairly good and was able to get up and get around.
Since Joe's resume procedure, we're able to spend much more quality time together, fewer interruptions, and we're just happier as a couple. The resume treatment has made a very big difference in our life.
Joe is very happy with his resume. And most guys are. So the other minimal option that a lot of guys talk about, hear about, see ads about is a UroLift. A UroLift we generally do in our outpatient surgery center. So we give a little bit of propofol, like when you get a colonoscopy, not a general anesthetic. And UroLift doesn't remove any tissue, doesn't destroy any tissue, doesn't shrink the prostate. It just moves that prostate tissue out of the way a little bit. So again, if you think about an orange that you're peeing through, and that's your prostate, resume goes through and basically desiccates some of that pulp, dries it up. UroLift goes through and pushes that pulp out to the side. I always tell people that we basically staple the channel open, and that's about exactly what it is. So there's permanent implants. They're safe. They don't set off airport scanners. You can get an MRI with them. Most guys don't have to have a catheter after a UroLift. We make you pee before you go home. 20 to 30% of guys can't do so because things are swollen or the anesthesia, and so have to go home with a catheter for a couple days. What I forgot to mention about a resume, the 5-year retreatment rate is 4.4%. So in other words, 5 years after a resume, 19 out of 20 guys do not need another procedure done. UroLift, it's about 15%, and recent studies would suggest maybe even a little bit higher than that. But resume and UroLift are the two minimally invasive outpatient, quick and easy things that we generally do, and they work pretty well. In my opinion, I think UroLift is probably a little bit better for smaller prostates, so a 30, 40, 50 gram prostate, whereas resume, I think, is probably better for a 50, 60, 70 gram prostate, because again, resume destroys prostate tissue, shrinks prostate, gets rid of some of that weight of the prostate. If you have a 70 gram prostate after or before a UroLift, you're going to have 70 grams of prostate afterwards. Green light is an outpatient procedure. A lot of my partners do this. Common thing that's done. I do not do this procedure. From my experience, I've seen a lot of worsening irritative symptoms afterwards. The obstructive symptoms improve, but that frequency and urgency, in my opinion, make this something that I don't have in my armament, because I think there's no prostate I can't treat other things in a better way. But very commonly done. A lot of my partners love it. Some of the WashU docs do a lot of this. A green light laser basically vaporizes prostate tissue. So we put a scope through. This is general anesthetics. You're totally out. And aim a laser at that prostate tissue and vaporize it. Retreatment rate's about 5% at 5 years. It can have a little bit of erectile dysfunction, not all that common, but that specific green light laser penetrates into that prostate tissue a little bit. And the nerves that control erections are on the outside of the orange, on the outside of the capsule. And so depending on how close that laser is to that capsule of the prostate, some of that energy can spread to the outside of the capsule and damage those nerves. Resume and UroLift generally has zero sexual dysfunction. Since this is a common procedure, we'll watch some of this green light video, probably not the whole thing. I think I accidentally stopped that, but that animation I think is helpful to see. I think it's a good illustration of what the prostate is. Again, you can kind of nicely see the what I call the rind of the orange here and all the pulp, and this vaporizes that pulp so that instead of peeing through, an orange, you're peeing through an orange with a much more open channel. And that's what all of these are meant to accomplish. So like I said, a lot of my partners do green light. I wouldn't discourage anybody from considering that if your doctor has recommended it. I just don't, for myself, think it's something that that I want to offer. TURP is a roto-rooter. This has been done since the 1800s. This is the gold standard for BPH. Has been for 100 years. In the hospital, general anesthesia, we put a scope through. We use a wire loop that would run some current through to carve away a lot of that prostate tissue. So with this, we do actually remove a good amount of the prostate, usually about 30 to 50% or so of the prostate volume. Usually have a catheter for a day or two. Oftentimes don't have to stay in the hospital, depending on how big your prostate is and how much bleeding you're having afterwards. But a lot of people go home the same day. Retreatment rate, lifetime's about 5 to 10%. So this is more durable than some of the others. Will cause, in about 70% of guys, permanent retrograde ejaculation, so lack of ejaculate, which again, Flomax does, but is reversible. Of course, if you stop the pill, 70% permanent with TURP. Sometimes when we carve away that tissue, the body heals by scarring. And so sometimes you get a little bit of scar tissue in the urethra that we generally can either do nothing about or dilate or cut with a little quick procedure. About a 2 to 3% chance of causing some erectile dysfunction trouble after a TURP, because again, that energy spreads to the outside of the prostate capsule, which is where the nerves live. Not a common issue after TURP, but it's possible. Again, basically no sexual dysfunction with a resume or a urolift. This slide should be replaced by HOLEP, holmium laser enucleation of the prostate. Is basically a simple prostatectomy. For larger prostates, and in my opinion, anything over 70, 80 grams is getting into HOLEP territory. What used to be done before we had the technology and the technique is cut your belly open, cut your bladder open, use our finger, shell out the pulp. And that's called a simple prostatectomy. Some people do that robotically now, so smaller incisions, but we still got to cut open your bladder. If there's somebody around that does a HOLEP, there's no real reason to go through all that. I do the most HOLEPs in St. Louis. I probably do the most within 200 miles. HOLEP stands for holmium laser enucleation of the prostate. So instead of going through the middle of the orange and carving away, which is a TURP, or desiccating, steaming, which is a resume, or moving out of the way, which is a urolift, through a scope in your urethra, I get into that space between the pulp and the rind, and just like you would do with an orange, if you use your finger and sweep around, I enucleate all of the pulp. So based on my last 100, I take out about 82% of the prostate volume. Lifetime retreatment rate is less than 1%. The fairly unique issue with that surgery is incontinence. So the bladder is so unobstructed after a HOLEP that the only thing in the way of the bladder and your underwear is your pelvic floor, the sphincter muscle. So half the women in the country leak when they sneeze because they don't have prostates. And after a HOLEP, you essentially don't have a prostate anymore for all intents and urinary purposes. And so at the beginning, after a HOLEP, oftentimes you go home the same day. Sometimes it's the next day. Catheter one day for most people. But when that catheter comes out after a HOLEP, guys are in diapers. And sometimes that's a couple days. Sometimes it's a couple weeks. Sometimes it's a couple months. About 30% of guys are still wearing a pad at 3 months, 1% at a year. So HoLEP is the certainly it's the most we can do. It's the most benefit. It's the most side effects. There is a solution for those massive prostates that none of my partners want to deal with, and that is send them to me. Insurance, all of these things are covered. All of these things are FDA approved. If insurance is giving us grief, we figure it out. I don't think I've never not done a procedure that is right for a patient because of an insurance company. So again, what the prostate is, it's a gland that helps out in reproduction when we're younger, causes trouble when we get older. LUTs, lower urinary tract symptoms, which are almost an inevitability as we get older, generally are from BPH, which is an enlarged prostate. Depending on certain clinical factors and what's going on with your bladder, infections, retention, et cetera, sometimes we don't do anything about it. Most guys at some point will be on pills for this. Resume and UroLift are quick 10-minute outpatient procedures that can help and do help much more than the pills. Generally not considered permanent lifelong cures, but certainly that's within the realm of possibility for either procedure. I think more likely a Resume than a UroLift. And then we do real surgery like a TURP and a HoLEP and green light. So if you don't have a urologist, I or all my partners are happy to see you. Primary care docs generally pretty good about screening guys for prostate cancer, talking about symptoms, starting medications like tamsulosin. But if you're beyond the mild symptoms on tamsulosin, that is in the realm of a urologist. And I'm happy to chat and answer any questions.
Beautiful. Thank you so much, Dr. Critchlow.